Welcome. In this video, we will learn how to identify different types of myocardial infarction or heart attack using ECG findings. By the end, you will be able to recognize ST elevation MI, non-ST elevation MI, anterior, inferior, lateral, septal, posterior, right ventricular infarcts, and important ECG patterns like Valence syndrome. Let us get started. Myocardial infarction occurs when blood flow through a coronary artery is blocked, causing heart muscle damage, and ECG is one of the fastest and most important tests for diagnosing a heart attack. The location of ST segment elevation or depression tells us which part of the heart is affected and which coronary artery may be blocked. In this video, we will cover acute ST elevation MI, acute non-ST elevation MI, anterior wall MI, inferior, lateral, septal, posterior wall MI, right ventricular MI, extensive anterior MI, subendocardial MI, Valence syndrome. Remember one rule, the ECG lead showing the abnormality points towards the injured part of the heart. Now, acute ST elevation MI. It occurs when a coronary artery is completely blocked. ECG findings include ST segment elevation in two or more contiguous leads, reciprocal ST depression in opposite leads. Later, pathological Q waves may develop. This is a medical emergency requiring immediate reperfusion therapy such as primary PCI or thrombolysis. Non-ST elevation MI. Unlike ST elevation MI, there is usually partial blockage of a coronary artery. Typical ECG findings include ST segment depression, T wave inversion. Sometimes the ECG may even appear normal. Diagnosis depends on elevated cardiac troponin levels together with the symptoms. Anterior wall MI. Basically, anterior wall MI affects the frontal wall of the left ventricle. The affected leads are V1 through V4, and ECG findings includes ST elevation in V1 to V4 leads, later development of pathological Q wave, T wave inversion during recovery. This usually indicates blockage of the left anterior descending artery, commonly called as the LAD. Now, inferior wall MI affects the lower part of the heart. Look for the ST elevation in leads 2, 3, and AVF. Reciprocal ST depression is commonly seen in leads 1 and AVL. The right coronary artery is the usual culprit, although the left circumflex artery can also be involved. Lateral wall MI. It affects the side of the left ventricle. The lateral side of the left ventricle. ECG changes appear in leads 1, AVL, V5, and V6, and you will see ST elevation in lateral leads, reciprocal depression in inferior leads, later T wave inversion, and the left circumflex artery is commonly responsible. The septal wall MI. Basically, the septum separates the right and left ventricles. The septal infarction mainly affects leads V1 and V2. Now look for ST elevation in V1 and V2, pathological Q waves later, T wave inversion during healing, and septal MI often occurs together with anterior wall MI because both involve the left anterior descending artery. Now, posterior wall MI. It is often missed because standard ECG leads don't directly view the back of the heart. Instead, you will see ST depression in V1 to V3, tall R waves in V1 to V3, upright T waves. Confirmation is obtained by placing posterior leads V7, V8, and V9 where ST elevation becomes visible. Now, right ventricular MI. It frequently accompanies inferior wall MI, and the best leads are right V3 and right V4, and findings include ST elevation in right-sided leads. Inferior leads changes may also be present. Recognizing this is important because these patients require careful fluid management and nitrates may worsen the hypotension. Now, the extensive anterior wall MI. An extensive anterior MI involves a large area supplied by the LAD. ECGs shows ST elevation extending from V1 through V6 and sometimes lead 1 and AVL. Deep Q waves often develop later. Because a large amount of heart muscle is affected, this type of carries a high risk of heart failure and cardiogenic shock. Subendocardial ischemia. Subendocardial MI ischemia affects the inner layer of the heart muscle without full thickness damage, and the typical ECG findings are widespread ST depression, T wave inversion, and no ST elevation. And this pattern is commonly seen in NSTEMI or severe coronary artery disease. Wellen syndrome is an important warning sign of critical lead stenosis. Patients may have little or no pain when the ECG is recorded, and characteristic findings include deeply inverted T waves in V2 and V3, or biphasic T waves in V2 and V3, and usually no ST elevation. And without urgent treatment, these patients are at very high risk of developing a large anterior ST elevation MI. Now to summarize, let us review ST elevation means ST elevation means STEMI, and ST depression often suggests ischemia or NSTEMI. And V1 to V4 equals anterior wall, 2, 3, and AVF represents the inferior wall, 1 AVL, V5, and V6 indicates the lateral wall, V1 and V2 reflects the septum. Posterior MI shows ST depression in V1 to V3, but ST elevation in V7 to V9. Right ventricular MI requires right-sided leads. Wellen syndrome predicts critical LAD disease. Learning these lead patterns make ECG interpretation much easier. Thank you for watching. If you found this ECG guide helpful, remember to like, share, and subscribe for more easy to understand medical education videos. Keep practicing ECG interpretation. The more tracing you see, the faster you will recognize the life-threatening heart attacks.